can.
Fantastic. Just let me know when you're ready for me to start. I know we've got another 5 minutes yet.
Can you hear me, Andrew, sir?
Yes, I can hear you.
Okay.
Can you hear me?
Yes, sir. Yes, sir.
Good. Okay.
Okay.
Just let me know when you're ready for me to start. 5 minutes.
Right. So.
Can you see my screen?
Yes, sir.
Good. I'm being patriotic.
Hi, Andrew.
Hey, Pramod.
Hi. I'm trying to make you the host for the meeting. I don't think it makes a difference now. Anyways, Sonal and Nehal has been assigned as co-hosts.
Good.
Just before you start, I think there are more people waiting to enter. Just at the time when you start the meeting, if you can just mention that any questions can be directed to the co-hosts at any point in time in their personal chat.
Yeah. Can you see my screen, Pramod?
Yes, I can see your screen, yes.
Okay, so it's got the slide on.
Yes, the first slide on, yes.
Okay.
Am I audible, Pramod? Okay.
Yes. So, Praveen, are you Praveen? Let me ask how many participants are there. Okay. There are 180 people who have joined the meeting now. A lot of people. So, okay. Now I have become the admin somehow. So I'm going to waiting 2, 3, 4. I'm just waiting for those who are waiting. Okay. Hello.
Hello.
Yeah, I'm just admitting all the people who are waiting. Okay. So give me a few minutes. We have 3 minutes left.
Okay. Okay.
So we are at 200. And we will be touching 300 RQ capacity soon. check how many people have. So,
We're not saying anything really right now. That's why you can't hear, guys.
It's okay.
They're saying they can't hear.
yeah.
You're not yet started, guys.
Had Amit been the co-host, he could have started singing for you. But
Let me see how many people. Let's see. Let's see how many people can.
Nehal, you look as though you're in a photo booth.
Okay, so we have 300 people. We are at 298, 299. Yes, I think you can go ahead and start.
yeah.
Okay, you ready for me?
Yeah.
Yeah, 4 o'clock. Yes, exactly on time. Yeah.
I'll start, sir.
Okay.
Andrew, sir. Shall I start, Pramod?
Yeah, you start, Sonal.
Go ahead, Sonal. Start this.
Someone's drawn on my screen.
Right. So good afternoon, everybody. It gives me great pleasure to invite you to the first of the 10 webinar series arranged by the Association of Oral and Maxillofacial Surgeons of India. We start today with condylar trauma, but the focus today is on management of early and late complications related to condylar fractures. So this is more of an advanced session. However, if there are any basic questions related to the topic, we would be happy to take them at the end. Now, may I introduce you to our speaker of the day, Mr. Andrew Sidebottom. He has been a consultant in oral and maxillofacial surgery in Nottingham, UK since 2001. He is an internationally recognized speaker and an expert in the management of TMJ, having carried out over 350 joint replacements and 2,000 arthroscopies. He is a patron of the ISTMJS, the Indian Society of TMJ Surgeons, and regularly lectures all over India. He is speaking today in the inaugural lecture series for AOMSI on management of condylar trauma complications. So, if you would start, please.
Thank you very much, Sonal. And welcome to England. I've worn an appropriate T-shirt you'll appreciate at the end, which is the Yorkshire County Cricket T-shirt. And in the background, you'll also see my Pride of Place ISTMJS patron, which Nehal kindly provided when I presented at the inaugural meeting in November at Pramod's small unit down in Kochi. So what I'm going to be talking about for the next 30 to 40 minutes is the post-traumatic management of condylar fracture complications. I'm not going to deal with initial management, indications, etc., as that will be a separate topic. So please, if you're going to ask questions about the post-traumatic management rather than the initial management. I will leave 3 or 4 spaces in the middle of the talk for questions. If you could address those to either Sonal or Nehal, and they will then pass those on. I will do about 3 or 4 questions at each stop, and then we'll leave time for questions at the end, if that's okay. So, post-traumatic management of condylar fracture complications. So the complications that we get with condylar fracture include malunion, non-union, ankylosis, and growth abnormalities. And apologies for the little red stripe down the slide. I don't know who put that there, but someone's been drawing on my slides since I put them up today. So whoever might have accidentally done that, if they could remove it, please, that would be great. So the choices of complication management, there's now a yellow one on there. So whoever did the yellow one has clearly put a yellow one and then a red one. Complication management choices, late reduction and fixation. And by late, I mean beyond 4 weeks. Condylar osteotomy, sagittal split osteotomy, inverted L osteotomy, distraction osteogenesis, LaFour-1, lateral release, gap arthroplasty, costochondrograft, and alloplastic replacement. And I will deal with each of those in turn, trying to illustrate as many of them as possible with cases. So the management choices, really, there are several important questions to ask when you're looking at a patient with a complication following a condylar fracture. Is joint function adequate? Is there joint pain? Is the occlusion adequate? Is there any cant? Has the growth arrested? And is there consequent facial anomaly? And I'll deal with each of those in turn. So is joint function adequate? This is a difficult question to ascertain what one would consider as normal joint function. I would normally suggest a mouth opening of 35 millimeters or more with a relatively normal dietary function. That means the ability to eat most things in the diet. If they are still unable to eat tough food, then that would be probably acceptable. And is there an ankylosis? Is there joint pain? Most TMJ surgery will not improve joint pain beyond 2 out of 10 at rest on a visual analog scale. And similarly, is the joint pain there on function, and does it get worse on function, which implies some internal derangement type problem or degenerative disease in the condylar head. Is the occlusion adequate? So has the patient developed an ipsilateral open bite or a contralateral open bite, suggestive of a change in their length of the ramus on one or both sides? Is there any cant? And is it upwards on the same side as the fracture, or is it downwards on the side of the fracture, or is there no cant? Now, cant will develop because of consequential growth of the maxillary teeth downwards into an open bite. So that would tend to be a late finding. Has the growth arrested? So is there evidence of an ankylosis?
Andrew, your screen is not sharing now, please.
Okay.
Can you share your screen again?
I seem to have lost connection with you all.
No, we can see you.
Hear you and see you, yes.
We can
See me?
hear you, but
Yes.
the screen is not.
Sure. Screen is invisible.
Can you hear me again now?
Yeah, we can hear you, but your screen is not shared.
So the host disabled my screen sharing. So whoever is the host has disabled me.
Praveen.
Yeah, can you see it now? Can you check, please?
Yeah.
Yeah.
Yeah, we can see it now.
Yes.
Got it? Okay. So where have we got to? So is there any cant? Is it upwards on one side? Is it downwards on the side? This is suggestive of dentoalveolar compensation and therefore is a late feature of a fracture with shortening of the ramus or lengthening of the ramus. Has the growth arrested? So is there ankylosis, or has the patient got what looks like a hemifacial microsomia from long-standing restriction of growth in the condyle? And therefore, is there consequent facial anomaly suggestive of either a full facial anomaly with compensation from long-standing shortening of the ramus and condylar undergrowth, or is there just evidence of a small condyle with condylar hypoplasia? And the first thing we need to look at with all forms of management is to do no harm. So practice all things in your dealing with disease, either help or do not harm the patient. So an overview of the indications for early surgery, which is based on consensus opinion. So if there is a condylar fracture with a malocclusion, shortening of greater than 2 millimeters, or a displacement of greater than 10 degrees, some people would say immediate open reduction internal fixation. My feeling is that you're better giving a trial of initial IMF elastics for 10 to 14 days, release the elastics, send the patient for repeat x-ray, and when they come back from x-ray half an hour later, if they've developed a malocclusion, at that stage, proceed to open reduction internal fixation. However, more urgent indication would be a malocclusion with shortening of greater than 5 millimeters, a displacement of greater than 30 degrees, or a dislocation of the condyle. I would consider early open reduction into internal fixation in those cases. And what it's important to appreciate is that you should attempt to get adequate fixation with 4 cortices on each side of the fracture. So which approach to the joint? And I think I've slipped into my old presentation here, so I'm just going to switch back. Yeah, I'm just going to switch into a different presentation. Apologies.
Request all participants to kindly stop your video, because otherwise it will be difficult to transmit a video and audio also.
Yeah,
Kindly
sorry.
stop your videos.
Yeah, that's the old one. No, sorry. I'll carry on with that one. I'd put one with slides in for questions, so apologies for that.
Shall I send that back to you, sir? I have the copy.
Yes.
Just check in your mail in sent item. Andrew.
Yes.
Okay. I can't find my mail on this. Hang on.
Request all participants kindly stop your video, because transmission will be difficult.
I can't find my mail on here.
We'll continue with this one then, sir.
Okay, if someone just ask the question. Sorry, I can't find my mail.
Okay, I know after which slide you have the space, sir. I'll ask you that time.
Okay.
Yeah.
So which approach to the joint. And we're all very aware that to get to the lower end of the condyle, at the condylar neck, you probably need some form of either submandibular, perimandibular or retromandibular approach. And to get to the upper end of the joint, the proximal end for condylar neck and head fractures, you need some form of pre-auricular approach. And there are various types of this, and I'm not going to discuss those in any more detail.
Oh, video ban.
Okay, so contraindications for open surgery would include inadequate conservative management, local infection, patient choice, the surgeon being inadequately trained to carry out the surgery, or having inadequate instrumentation or inadequate plating system for the fracture type to be able to immobilize it. So what I propose is we need to have an orthopedic basis to manage condylar fractures. So that basically means we preserve the normal anatomy as much as possible. This both reduces morbidity, improves function, and aims to correct the occlusion. And to quote a famous Indian, freedom is not worth having if it does not include the freedom to make mistakes. But what we need to do is learn from them. And similarly, insanity is doing the same thing over and over again and expecting different results, which is from Einstein. So if you found a technique and it doesn't work, don't carry on doing that. Try something different. So are we about ready for questions?
So one of the questions was, sir, that do you mean 4 cortices on either side?
Ideally, you need 4 cortices on either side, yes, for fixation.
Another question was that if the occlusion is normal, but if there is deviation upon mouth opening.
So I think my opinion on that is that having done a lot of joint replacement, you lose the lateral pterygoid attachment, and 50% of the patients do not regain lateral deviation, but they maintain normal function, so they can eat normally and they can function normally. So it doesn't really matter if the patient, in my opinion, deviates. There's a very Germanic approach to this. The Germans want to correct patients who have a deviated mouth opening. I don't think that that's essential, because if the patient has a good function, the only thing that you're seeing with a deviated opening is cosmetic. If they're functioning well, if they're eating well, if they're opening well, it doesn't matter if they're deviated, in my opinion.
So would there be any role of Botox, sir?
Botox is really, I would reserve for use with pain. It can be useful in condylar head fractures to reduce the pull of the lateral pterygoid, pulling off the condylar head. But routinely, I wouldn't use Botox for the management of a condylar fracture.
Right. Nehal,
Yes.
any questions to you?
No.
Okay. And so then there was a question about what are the chances of a child versus an adolescent versus an adult getting ankylosis? Who ankyloses more? And...
I think there are a lot of theories about why people get ankylosis. I think the most important thing in terms of prevention of ankylosis is mobilization. So immobilizing a patient post-operatively after a condylar fracture, in my view, is not indicated. If you've got a patient in a good occlusion, you want them in elastic traction to keep them moving, but to maintain the occlusion. The issue with formation of ankylosis is probably related to bleeding in the joint and blood then reorganizing, and it can't reorganize itself into bone if it's constantly moving. So mobilization is the key to prevention of ankylosis in both children and adults. And the difficulty is mobilization from pain. So therefore adequate pain management facilitates mobilization.
Right. Oh, there's another question. So what is adequate conservative management? How much is adequate? How many days?
I think what conservative management means is basically mobilizing the joint and maintaining pain-free so that they maintain a good occlusion. We all know that if you leave a fracture with a mild malocclusion over the course of about 6 months, it will correct itself. So accepting that if there is a significant open bite, which you'll see from the case that's just coming up, at 4 to 6 weeks, then you would go in there. If this is a millimetre or so, you might expect that to correct itself and therefore take an expectant role with guiding elastics, not tight elastics, guiding elastics, just to guide the occlusion to the right place. So we don't know what adequate is, but what is essential is mobilization and trying to maintain a good occlusion.
Andrew, there is one question.
Yep.
So, which is the best approach to open a condyle in case of malunion? Say it's a subcondylar fracture.
Sure, I'll be discussing that shortly.
Yeah.
Then there is that age-old question, sir. Open versus closed. Which one has better results?
No. The question is, see, there are
That's a
questions which
different
are coming on a YouTube. So I am directly directing the questions from the YouTube. So somebody is asking, which will be the best approach to open in case of malunited condylar neck fracture, whether it will be auricular, retromandibular, what approach will you choose?
So this I'm going to discuss in a short while, Nehal.
Yeah, so I just told them same thing. The second question is, in case of bilateral condyle fracture, which condyle will you approach first? It is, if say it's on the subcondyle and one is on the neck, both are medially displaced fracture.
So I think, again, we're straying off the topic, which is post-traumatic condylar complications. So this isn't initial condylar management. So that's a different topic altogether.
Okay, there is one more. Can I ask last question, Andrew?
Yeah.
So, yeah, I think you already mentioned. I'll ask next time. I mean, in next slide when we will talk about the.
If we have, yes.
Okay.
Yeah, you can carry on. You can start.
Okay. So late open reduction internal fixation. Basically, I would consider this at 6 weeks following conservative management, with either a late change in occlusion or a persistent malocclusion despite elastic traction in a patient who has been managed by a surgeon who doesn't really want to open a condyle or can't open a condyle. And I see this relatively commonly in the UK because there aren't that many surgeons that are happy to open condyles. So this is a classic example of a girl who is 6 weeks down the line following conservative management of a condylar fracture on the left side, who has premature contacts on the right side, on the ipsilateral side, and an open bite on the contralateral side. The root-filled tooth that you can see, lower right 6, is a recent root canal filling, so an asymptomatic, so we aren't dealing with that at all. So with this patient, you have to warn the patient that you may need to graft the site, or you may need to actually fracture the site if you can't mobilize it with just splitting it with an osteotome. So always warn the patient that you may need to take some form of bone graft. So in this case, we managed to reduce the fracture and immobilize it using 2 4-hole synthese mandible plates. There is one screw that you can see there, which is, because the fracture was like a sagittal fracture, I've immobilized that initially with a bicortical screw. So the lateral aspect is going through the condylar fragment, the medial aspect is going through the mandibular fragment. And that's why it looks as though I've missed the hole with the screw. And indeed, this patient came back to a clinic with one of the registrars, had a look at it and went to another consultant and said, "Oh, Mr. Sidebottom's missed the hole in the screw." But in fact, this was a purposeful bicortical screw placed in that position. And the patient has a stable occlusion. She has good mouth opening. She's now 2 years down the line with a mouth opening of 33 millimeters, no deviation. I opened through a retromandibular approach only. The proximal fragment slipped back into position very easily, and I wasn't concerned about the disc or damage to the disc. However, if I was concerned about damage to the disc, I would consider opening superiorly by a pre-auricular approach and then reducing the disc. And that tends to be the case when you've got higher condylar neck fractures or condylar head fractures and the condyle displaced off medially or anteriorly dislocated. You need to replace the disc back into position, and that tends to pull the condyle back and the pterygoid back. And those cases are ones where you might want to consider putting some Botox in the lateral pterygoid at the same time. So the indications for a condylar osteotomy are shortening of the ramus of less than 5 millimeters with an intact condylar head and disc. For this procedure, I will go through a retromandibular approach. I will make the cut ideally with the piezo saw, as it minimizes the amount of bone removal and bone debris. Then reposition the proximal fragment. And if it doesn't reposition easily into the fossa, then it may be necessary to open the fossa from above and reposition it physically in the fossa. They then need two-plate fixation, and invariably they will have a gap, and they probably would ideally benefit from cancellous chips placed in that as an interposition bone graft into that. So I would routinely warn the patient that they're going to need an interposition iliac bone graft using cancellous chips placed into that defect. I've done 2 or 3 of these where I haven't put the bone graft in and they haven't united properly. So this is a patient treated elsewhere who had a malocclusion with a fracture malunion stroke non-union. And you can see from the site here that there is non-union of where that plate's been put in. And you can also see from this x-ray that they've got what we call Tetley tea bags, multiple perforations where they've tried to fix it on a number of previous occasions. So with that patient, I went back in, I took out the old plate, I osteotomized the condylar fragment because there was a fibrous union across here, then repositioned it into the correct position, stabilized it with 4 proximal cortices and 1, 2, 3, 4, 5, 6, 7 distal cortices. And I've taken a ramus graft from here and packed that into the defect. And then we mobilize the patient. We've got IMF screws in place for elastic guidance of the occlusion. We then mobilize the patient. And again, they get a good result down the line with mobilization. IMF elastics, I tend to leave for 2 weeks at most, if possible, to just stabilize the occlusion in the immediate postoperative phase. Sagittal split osteotomy is the next. So the indications for a sagittal split would be a malocclusion with good joint function. So this patient had a mouth opening of 46 millimeters. No pain in the joint. She has a small lateral open bite on the contralateral side around here. She's got a head fracture, head or neck fracture. That will be difficult to osteotomize, stabilize, and put back in the right position. And she's got shortening of the ramus of less than 5 millimeters. Now, there's a lot of talk about, with sagittal splits, closing anterior open bites. What I would say with these is that you've already had a ramus that has been the correct length. So lengthening that ramus back again should not be a problem. The way I do sagittal splits as well, I will physically free the pterygomasseteric sling through the split, cut the periosteum so that it frees it, so it puts less vertical pressure onto the condylar head. And then just do a standard sagittal split osteotomy, correct the occlusion, simple 4-hole fixation, which is standard sagittal split guidance elastics, and then mobilize the patient. And this patient is now over a year down the line, normal occlusion, 46 millimeters of mouth opening. Inverted L osteotomy, again, the patient should have good TMJ function, that is no pain and good mouth opening. They have a contralateral open bite. I tend to prefer this in adults or in adolescents who don't want to have distraction. I like distraction in adolescents because it leaves the mandible without taking a bone graft. Invariably, an inverted L will require a bone graft placing into the defect that's generated. So this is a patient who initially presented elsewhere with quite a straightforward condylar neck fracture, which should have been amenable to reasonably good fixation. So they decided to manage it with a sagittal split down the line, as conservative measures hadn't worked. They had a bad split on the proximal fragment on the left side, so they placed a long rigid plate which wasn't rigid enough and fractured. They then went back in and made a larger plate, but unfortunately that led to the condylar fragment displacing off and a malocclusion. So the patient was then left with an open bite bilaterally following the sagittal split due to slippage of all of the fragments. So the fragment was united, but they had an anterior open bite. The condyle is in the fossa. The patient has no joint pain and 36 millimeters of opening. So we did an inverted L osteotomy through a retromandibular approach using the piezo saw to make nice fine cut. We separate the fragments, pack in a bone graft, place 2 4-hole plate fixation to stabilize it, and bone grafts in the defect. The patient had previously been seen by a colleague in London at a private clinic and told that the only way they could treat him was with a bilateral joint replacement. Remember, this is in a patient with mouth opening of 36 millimeters and no pain. So this is the patient beforehand with the healed fragment, but it's off-ended at an angle, and then it's healed at this position. And bilateral inverted L osteotomy corrected the occlusion, put them into elastic traction for 2 to 3 weeks. And this is a year down the line with good healing, mouth opening of 35 millimeters, no pain, good joint function, and no joint replacement in there. So the patient was happy. We know that joint replacements will ultimately fail, maybe 10, maybe 20, maybe 30 years down the line. But we also know that a sagittal split or an inverted L, once it's united, is not going to fail in the long term.
So
I think this is where we next have questions.
Yes, sir. Yes, sir.
So there are a couple of questions, Andrew. The first question is, any specific precautions to be taken while osteotomizing the condyle when you do a revision?
Okay, so the reason I would use the piezo is so that you have minimal risk of damage to the underlying maxillary or the mesenteric vessel. So you need good exposure of the ramus, good exposure of the sigmoid notch. And anyone who has been on one of the courses that I've taught on will know that I love the Dundo tray retractor. That goes very nicely into the sigmoid notch. I also tend to use a Minnesota type retractor on the posterior border of the mandible. Then that can get as far around the medial side of the condylar fragment as possible. So you're trying to retract as much of the medial periosteum as possible, and therefore pulling away the mesenteric branch of the maxillary artery and the maxillary artery. Using the piezo also will prevent that, but if you're going to use a saw or a drill, I would always suggest cutting from medial to lateral. So you get the saw in on the medial side and cut out towards yourself. So again, you're not risking cutting medially into the vessels that are lying just deep to where you are.
Okay, so now the second question is, when you do a bilateral sagittal split osteotomy for correction of the occlusion, do you do only on the affected side, or it's, I mean, it has to be bilateral, right?
So the issue
SSO.
with, the issue with choosing between doing a unilateral and a bilateral is really related to the fact that when you release the sagittal split on the same side as the condylar fracture and then reposition things, you're going to cause condylar torque on the contralateral side. So to compensate for that, I would tend to do a bilateral sagittal split. The alternative is to do a VSS, and you could then get away with probably doing an ipsilateral VSS. But I prefer, because you're moving the jaw forward and downwards, a VSS might leave a gap and therefore cause a problem. So I would tend to do a sagittal split. I would tend to do it bilaterally to compensate for the contralateral condylar torque.
Okay. The last question. Is the interval between the post-trauma and the malocclusion critical variable in decision making? I mean, when you do your...
Yeah. So I wouldn't plan to do an osteotomy until at least 6 months down the line. The reason for that is so that you've got good, solid, healed bone that you're cutting into. And that may be a sagittal split or a condylar osteotomy. You need good bone there. However, if you go into a fracture 6-8 weeks down the line and it seems to be uniting, you may be able to split where the early union is using an osteotome. But if you can't and you're already in there, then you make your osteotomy cut at that stage. So your initial plan for a patient early in the phase before 3 months would be to try and split where the fracture has been, but with a backup plan to osteotomize the condyle if that doesn't work, warning the patient that you may need to take a bone graft as well to stabilize things.
Okay, and what bone graft? Which
so
will you prefer to harvest the bone graft?
So a bone graft, 2 millimeters or less, I will probably accept using a little bit of ramus. Anything more than 2 millimeters, I want cancellous chips in there.
So what is the reason
And
for choosing? Sorry, go ahead.
So
Yeah.
do you reposition the disc while reoperating the condyle?
So if the condyle seats into the fossa,
do you reposition the disc?
Yeah. If the condyle seats into the fossa from below and it seems stable, I don't reposition the disc. If it doesn't seem stable or if it's been dislocated, then I will go in from above and reposition the disc at the same time.
And what kind of fixation do you prefer, 2 mm or 1.5 mm plates?
For plates, I always use 2 mm.
Okay. Yeah, Sonal, you can ask because.
Yeah. So there is a grating noise after open or closed reduction. What would the management be?
Reassurance. We don't treat the music, as they say in America.
Right.
And do you open the joint during
seriously though, I think you need to consider what might be causing the grating noise. If you think that your plate has gone too long, and I've certainly seen plates for condylar fractures which are engaging the skull base, then you need to be very concerned about that. Similarly, I've seen screws go through the condylar head and into the joint space. So I think you would investigate it to make sure that there isn't metalwork causing problems. But otherwise, if the joint's mobilizing well with minimal pain and it's just a noise, you just tell them to accept the noise.
So what is the exact marker that the condyle is in the correct position, sir, intraoperatively?
Feel.
Mm-hmm.
It will feel as though it's in the right place. So it sits passively. It's the same as with the sagittal split.
Right.
With a sagittal split, you're seating the condyle vertically. If you push up vertically and it sits stably, you can't move it forwards and backwards, and then it aligns with the posterior ramus, then you're pretty certain that you've got it in about the right place. We all know that with sagittal split, we're never completely in the right place, and there will be a degree of remodeling the vast majority of cases where we do sagittal split. What we're hoping for in any form of TMJ or orthognathic surgery is that the condylar remodeling is a stable process which is controlled rather than an unstable process which proceeds to condylar resorption.
Right. And what would be the reason for choosing an inverted L, sir, over BSSO?
So if I want to lengthen the ramus, in a patient more than about 1 millimeter or 2.
Right. Maybe we can go ahead now, sir.
Okay.
Come back with more questions later.
So just a little bit about malunion of pediatric fractures and secondary ankylosis. So the alternatives for management of these is a lateral release and disc interpositioning, a gap arthroplasty plus or minus costochondrograph if you believe in those, distraction of the ramus and a secondary gap arthroplasty for the ankylosis, or alloplastic replacement. And increasingly, we are considering alloplastic replacement for younger and younger patients around the Western world. So this is based on a large study from Jaipur, from on the management of a lateral third ankylosis, so a type 3 ankylosis, which I know most of you in India will have seen hundreds of. I've seen 3. So I don't have huge experience on this. You can probably teach me more than I can teach you. But what you're looking for in these patients is the intact medial side of the condyle. So they will have had probably a vertical split fracture of the condyle with displacement of the lateral fragment and then union of the lateral fragment against the base of the zygomatic arch and the fossa. So with these patients, you can open the joint, and this is by a preauricular approach. You can see I do a very limited approach with no extension into the hairline. Then I've done a wedge excision of the area using the piezo saw. We take out the wedge of tissue here, and then you can see the disc tissue medially, which is coming up around here, which you can pull over the condylar head. This is where you become aware of why I'm wearing this t-shirt, because then we are cheapskates in Yorkshire. They call Yorkshiremen tight Scotsmen, and Scotsmen's purses have moths coming out of them whenever they open them. So you find the disc, you then pull it over. And this is a 1.5 millimeter screw in the lateral pole, and there's a similar screw you can see there in the posterior pole. I will then loop around PDS in the lateral pole here and double loop it around the screw. And similarly, the posterior pole and double loop it around the screw and then tie it back. And that's like using a Mitec anchor, but these screws cost about 90 UK pounds each, as opposed to 1,000 UK pounds for a Mitec anchor. So it's a Yorkshireman screw because I'm a tight man. So the Yorkshireman screw is an alternative to a Mitec anchor, which is cheaper. And my last fellow, who I think is listening online, is going to write this up as a technical note. So you use 2 standard 1.5 millimeter screws. You can alternatively use a resorbable screw if you're concerned that this may cause some form of erosion. 6, 7 millimeter long, tighten it up to within 1 millimeter. So you've got enough room to loop your PDS around it. You place one in the posterior condylar neck, one in the lateral condylar neck. You pull the disc back into position, double loop the PDS through the retrodiscal tissues, and pull the disc back down around these screws with a double loop and tie. So that's the Yorkshireman screw. So this is a patient that I did it on, which you've seen the CT scan of before. Here are the 2 Yorkshireman screws. 1 year post-op, 42 millimeters of opening, pain-free. But you can see she has some deviation towards that side on opening. She's now 3 years down the line, 18 years old. She was 13 when she had it done. Sorry, 5 years down the line. She was 13 when she had it done. And she still has maintained this 42 millimeter opening. She has her own joint. She has full facial nerve function with no weakness of the forehead and is pain-free. Distraction. So distraction osteogenesis, you can do a vertical ramus distraction to make a neocondyle if they've previously had a gap arthroplasty for managing the condylar fracture. The alternative is to do it straight away with a vertically sliding VSS. Ramus lengthening, you can consider with an intact joint with good function. This can level the cant and correct the center line, and I will go through how we do that in the next few slides. The alternative to do it in one stage is with an inverted L osteotomy. For correction of ankylosis, there is some debate on whether you should do the ramus lengthening first and then the ankylosis release, or the other way around. I prefer to lengthen the ramus first, rotate it round, correct the occlusion, and then release the ankylosis at the time that I remove the distractor. And I tend to use internal distractors because we can 3D plan them, like with this case. So this is a girl who in fact has a inflammatory arthritis, loss of vertical height of the ramus, and vertical height there. The center line here does not correspond with the center line here. And you can see she has an occlusal cant. So we take this to the lab. The lab will then, this is a really old case. So this was when we had hard plastic models. We now have soft plastic models. The lab will make the model. They will move to correct occlusion, to correct the center lines, and lengthen the ramus. And that will leave you with a lateral open bile. Now, in teenagers, that will close itself with compensatory dentoalveolar growth. The lab will then pre-bend KLS Zurich distractor and then make a template to show me the plan of where I'm going to put the distractor. And I like to overcorrect by about 1 to 2 millimeters. So this is the template which fits around the angle of the mandible with the pre-drilled screw holes, pre-bent distractor. We then do a short retromandibular approach, come in to the joint, place the template against the mandible, drill the holes there, and the proximal end is where we're making the cut in the osteotomy cut. So there's the osteotomy cut made as well, pre-drilled holes. Place the distractor then against the mandible and port it out through the submandibular skin. Often you'll be able to port it out through the front end of the wound, but sometimes, depending on your vector, you can't. Then close the wound, turn the screw 0.5 millimeter twice daily from 5 days onwards. And you can get up to 15 millimeters of movement with these Zurich distractors, but usually only about 10 is necessary. You can then see that the scar, even 6 weeks down the line, is hidden behind the angle of the mandible. So you get lengthening of the ramus to level the ramus. You get correction of the midline there and correction of the midline here. And she's still a little chubby here because of swelling post-op. But a good result with mouth opening of 38 millimeters, no further need to surgery. She was operated on in 2012 and she's now 8 years post-op, 12 years old at the time. She's now 20, still functioning well, no joint pain, with a joint that looks abnormal, but is functioning well. Postochondral graft. Sorry?
The questions, yes,
yeah,
sir.
okay.
Yes, sir. So suppose a patient comes to us after release of ankylosis, and then the vertical ramus is short, and we do a ramal distraction osteogenesis. So then, what are the what is the possibility of developing ankylosis in those cases?
I think that there's always a possibility of developing re-ankylosis with any case. I think the key to all of the cases of ankylosis, as I've said before, is mobilizing the patient post-op to try and prevent that. Using a distractor, you've got fairly rigid fixation in there already, so you should be able to mobilize the patient early. What you're relying on with the distractor, if you're doing a vertical ramus VSS to form a neocondyle, is that it pushes the soft tissues before it and forms a neodisc at the top. If that works, that's great, because you then need to just mobilize the joint and get things moving. The risk of ankylosis, I think there have been not enough studies to look at that risk with a consistent way of managing the distraction.
Then there was a question about the last patient, sir, that how was the cant corrected?
So let me go back the slides. What you can see has happened with this is that the distractor has been placed at an angle. Okay, so we've got lengthening of the ramus in that direction, and we've got correction of the AP dimension. So the vector of distraction has a vertical vector and a horizontal vector, which is why when you position that, you then place your distractor open in that position, fix the distractor, pre-bend your distractor and fix it in that position, and then move it back to where it was. So you've got your vector fitted against the mandible in the right position. So it corrects the horizontal and vertical direction. You then get this lateral open bite. You can control the cant by holding back the lower teeth and allowing the upper teeth to over-erupt with dentoalveolar compensation.
Right. Nehal, do you have any questions?
So, Andrew, there is one question that after secondary treatment of condyle fracture, mobilize the patient. I mean, when you start the, is it early or do you have to wait? Do you give a intermaxillary fixation for some time?
So for post-traumatic management, I will tend to put them in light elastics for 2 weeks, but get them mobilizing early. So the elastics are really to just guide the muscles into the right, to readapt themselves into the right position once you've stripped them off the ramus of the mandible. So it's allowing the mandibular muscles to reposition themselves to fit with the occlusion. And then I will mobilize them actively from 2 weeks onwards. But in the meantime, they will be opening and closing.
Okay. We can go ahead.
Yeah, there's one question that I have, that what, after the correction of the ramal height, after how much time of that would you consider gap arthroplasty?
So I tend to wait based on the fact of 1 millimeter movement, 1 week wait for allowing for the bone to consolidate. So if you've lengthened the ramus by 10 millimeters, you want to be at least 3 months before you take off the distractor and then do the gap arthroplasty or whatever you wish to do with the ankylosis.
Right. And then
So
lastly,
a millimeter a week. Wait.
how much of open bite can we expect to be corrected if we leave the maxilla alone and for some time, as you said?
So I've done distraction where I've had an 8 millimeter lateral open bite, and I see the patient when I finish the distraction at 2 weeks down the line, and I see them again at 6 weeks, and by that stage most of the lateral open bite is closed. So the dentoalveolar growth in younger patients, this is patients 12 to probably 18, but I've certainly had 5 millimeter lateral open bite closures in patients in the early 20s. You will get both arches want to close down, but what you want to do is try and control the mandibular arch so that the maxilla grows down. If you look at Nitzan's work, where they're correcting condylar hyperplasia, and they're resecting it based on the degree of cant at that stage, and they're leaving the patient with a huge lateral open bite on that side, on the opposite side. Over the course of a year, that closes down, and these are patients with sometimes 7, 8, 9, 10 millimeters of open bite. So be expectant. Wait a year until you think about it. Always warn the patient that they may need a second stage maxillary osteotomy, but hold back the mandibular teeth, allow the maxillary teeth to go down, and use that to help control it. And I haven't yet had to do a second stage maxillary osteotomy.
Right. We can carry on, sir.
Okay. So I'm briefly mentioning costochondral graft. I don't use costochondral graft in my routine practice. I've done 2 as a consultant, both in children. The reason for that is that we're increasingly seeing that their long-term success of about up to 10 years is around 30%. So before 10 years, more than 2/3 of them will fail due to either re-ankylosis, overgrowth, or collapse. There's also significant second donor site morbidity, which includes pleural effusions, infections at that donor site. So largely I've abandoned using that. The healing phase also requires immobilization, and it takes up to about 6 months for cortex to cortex healing to occur in monkeys, according to studies from Reitzig. There's also poor anatomic fit and function of this. So there's a tendency for early failure. There's also a tendency for late failure due to collapse or re-ankylosis. Its occasional use is suggested in childhood ankylosis, although increasingly we're looking in, certainly at Great Ormond Street and other major centres doing paediatric maxillofacial surgery for patients with ankylosis, are increasingly looking at alloplastic replacement using metal on high molecular weight polyethylene for fixation, for management of the ankylosis. So finally, moving on to TMJ replacement. So where does this fit in with post-condylar fracture management? Well, it fits in with those patients who have developed an ankylosis or who have developed a malocclusion with increasing pain in and around the joint. So you need to deal with the pain in the joint as well as the malocclusion. The contraindications to joint replacement: active local infection, poorly controlled diabetes, and severe medical limitations, such as limitations to ability to have a safe general anesthesia. So the two main prostheses that we use in the UK are the Biomet prosthesis, which can be stock or custom. It consists of a high molecular weight polyethylene fossa with titanium screws to fix it, and a titanium ramus with a cobalt chromium condylar head. The TMJ Concepts is only available in custom fitting, and you get a 3D CT scan. They then plan your resection for you, make the prosthesis, and even tell you what length of screw you should use. This is titanium ramus, usually cobalt chrome, but can be titanium head, molecular polyethylene, and a titanium base plate. And the fit with this is more positive than with the Biomet prosthesis. And the theory is that this bit integrates with the bone. Having taken out probably about 10 of these, I've only found one that is integrated with the bone. So that doesn't always work. The TMJ Concepts prosthesis, it looks as though it's dislocated on the scan because you've got the high molecular weight polyethylene between the ramus and the fossa. And the ramus should run down the posterior border and along the lower border. You should not have a gap between where the ramus prosthesis fits against the ramus and the ramus, because if there's a gap there, it will tend to rock and it will tend to cause the proximal screw to fail and then the whole prosthesis to fail. Similarly, if you've tilted it forward, there's a significant risk of damage to the inferior alveolar nerve. So in the UK, the mean age for joint replacement is around 43, 80% female, 20% male. And what we find is that a small proportion, so that's 30 of 300 patients, so around about 10% are post-traumatic. So not very many end up needing joint replacement. And considering we do a lot of condylar trauma in the UK still, that's quite a small number. The majority being osteoarthritis, small number of ankylosis, and similar number of previous multiple failed surgeries. So, alloplastic replacement. This is a patient with a central dislocation of the condyle, which occurred 10 years previously. And you can see it's gone right through the fossa, and the fragments are extending along the back end there. The patient was getting progressive headaches and seizures, and subsequently limited mouth opening. So, via an extended, and this is one of the few occasions where you see me do a Brownlee RKF, I've cut through the temporalis fascia and straight through the temporalis to the base of the arch, stripped along the arch, expose the joint below, and we can then expose through a limited craniotomy, just here, to get into the condylar head, which is coming through into the middle cranial fossa. The dura is reflected, and we remove the proximal fragment, and then we remove the distal fragment in the same fashion. We will then place the TMJ Concepts prosthesis, and it has a titanium base plate. So it acts as the cranioplasty, and as you can see here, it covers the cranioplasty defect very well. So the defect is covered by the titanium base plate. I wouldn't be as confident of using a biomet prosthesis to cover that because it's not as rigid. And this is the patient who came in 6 months later with complaining of a headache, and the local hospital took plain x-rays, and thank you very much to them for doing that, because it gave me a chance to have these slides which show it very nicely sitting right over where we want it to be sitting. So it works very well for that central dislocation case. And again, as you see, sitting down the posterior ramus along the lower border, clear of the infraalveolar nerve, patient with mouth opening of 44 millimeters post-op and no pain. And she's now just over 18 months post-op. Finally, this is a case of a child who had a medially displaced fracture when younger and has a consequent relative hemifacial hypoplasia. So they've got short ramus, limited opening, and this area here is very restricted. So with that, I'm doing a standard TMJ Concepts prosthesis, lengthening the ramus, giving them a lateral open bite there, which you can see, using the prosthesis to do that. I haven't got the post-op pictures of this patient, but I've seen him at 1 year, and he has a level occlusal plane with a tiny bit of cant still here. So he has about 2 millimeters up here, as opposed to at the start 8 millimeters up. So he's had some mandibular compensation, but both his ramus lengths are correct. This is what we've done with the prosthesis. You can see the open bite here, which we've corrected. And that closed up over the course of 1 year. His mouth opening of 32 millimeters with no pain in the joint. And that's what it looked like in position. So finishing off, the management choices are really based on, is the joint function adequate? Is there joint pain? Is the occlusion adequate? Is there any cant? Has the growth arrested? And is there any consequent facial anomaly which you need to correct? Take into consideration all of those questions. It will give you a stepwise plan as to how you should be managing them. So if the joint function is adequate and there's no joint pain, leave the joint alone. If there's growth arrest, then deal with the growth arrest and then deal with the joint so that you get functional correction.
Andrew.
So we've gone through all the management choices: late reduction fixation, condylar osteotomy, sagittal split, the 4-1, inverted L, distraction, lateral release, gap arthroplasty, costochondrograph, and alloplastic joint replacement. Thank you very much.
Can I ask you a question?
Yes.
So, in case of medially displaced condyle fracture without any occlusal discrepancy, what is your opinion? What would you do?
I would, if they've got good opening, no pain, and no occlusal discrepancy, I would just tend to mobilize them. That's what we've done for years and years and years until now. And it's only with the advent of being able to do open reduction into fixation that we're thinking, okay, perhaps we should treat these. But if the patient is functioning well and they've got minimal pain, then why fix something that is going to remodel on its own?
Okay. Second question is, what is the youngest age you can do a joint replacement?
So the international guidance is 16. However, there are more than 30 patients that have had joint replacement done now who have been under 16 around the world. Certainly the study which, the patient which Jim Swift and Lou McCurry carried out, patient had had 4 costochondrographs previously, at age 12 had an alloplastic replacement. At age 20, he was getting normal relative growth around the joint replacement due to Moss's functional basis of growth. And his mouth opening was maintained at 40 millimeters. So there is certainly increasing evidence that we can be doing alloplastic replacement in younger patients. But I think what you've got to think is that if you place it at age 7, the patient is going to grow. If you don't get functional growth on that side, then you're condemning the patient to either an osteotomy or distraction or revision of the joint replacement at some stage down the line. Now, the alternative to that is to say, well, okay, if we put in a costochondrograph, it's going to fail. So we're condemning them to to something else down the line anyway. If we do a gap arthroplasty, we're looking at a 30% risk that it will re-ankylose. So again, will that be something that we have to revise down the line? So it's those considerations that you have to bear in mind when you're thinking about potentially doing an alloplast in a younger patient.
Okay. There's one more question. So in case of lateral ankylosis, when you release the ankylosis, would you put anything interpositionally to prevent re-ankylosis?
So again, the lateral third ostectomy, you tend to have intact disc. So I pull the disc back through. The 3 cases I've done, the intact disc has been there. So I've pulled the intact disc back, and that's been my interposition.
Okay.
So there was a question, how do we choose when to do osteotomy, when to distract, and when to do alloplastic reconstruction?
Okay, so that's based on the questions that we're asking. So condylar osteotomy and distraction for a normal joint, i.e. a joint which is pain-free with good function. Alloplastic replacement for an abnormal joint with pain and limited function.
So are there any indications at all for primary use of alloplastic replacement after condylar fracture?
That's a question I've been asked on a number of occasions. I think you've only got to look at patients 6-9 months down the line with comminuted condylar fractures to see that a lot of them will remodel on their own. So I think we've got to give every chance for the body to heal itself before we start putting something artificial in there, because we do know that an alloplastic replacement will ultimately fail. And a lot of these patients that have got condylar fractures tend to be under 30. So if it lasts 20 years, they're going to need at least 2 revisions in their lifetime. So my feeling moving forwards, the more joint replacements I've done, the less inclined I am to do joint replacement as a primary option. I'm amazed by the body's ability to heal itself.
So, okay. So what is the sequence for TGR with concomitant orthognathic surgery, Andrew?
So for the case that I showed, the lad was 16. I've done a unilateral condylar total joint replacement, and I will review him at 1 year. If at that stage his occlusal cant hasn't corrected, then I would do a LA4-1. Older patients where we're not going to expect any form of occlusal cant correction, I would do the osteotomy at the same stage as the joint replacement. The staging would be joint replacement first, osteotomy second during the operation. So you need to be absolutely certain that when you put your joint replacement, when you plan your joint replacement, you're getting an advancement of the maxilla or at least the maxilla staying exactly where it is in the AP position. Otherwise, if you plan it such that there's a maxilla pushback, you know how difficult that is to achieve.
Sonal, do you have a question?
Sir, what are the various methods to reduce the condyle? Regarding the lost ramal height, how would you regain the ramal height? Various methods.
So in the post-traumatic condition, you want to put the condylar fragment back in its normal position in the fossa, or as near normal position in the fossa as you can. You then correct the occlusion, and you've got the condyle passively seated in the fossa. You then have the gap between the length of the ramus with the occlusion fixed in IMF and the condylar fragment, and that's the gap to lengthen the ramus. If you're talking about planning it on distraction, using a 3D model, you aim for a balance of length on both sides.
Then what are the chances of getting TMJ disorders in conservatively managed joints?
You know, it's like everything else. The degree of development of TMD following trauma is very variable. It varies between people. It varies between the degree of the trauma. We all know that there's a significant psychological element. So patients who have been assaulted may not do as well as those who've been involved in a road traffic crash. However, those that have been involved in a road traffic crash that are pursuing litigious compensation may similarly end up with significant myofascial pain and therefore joint-related pain. So it's unpredictable is the honest answer to that. We don't know how many patients who have had trauma end up with temporomandibular disorders. And the guys that do the medical legal reporting will say anyone who's had a whiplash type injury or any injury to the face will develop temporomandibular disorder. Well, yeah, how much of that is the stress of the situation? How much of that is the stress of following medical legal response? How much of that is the original injury? It's very difficult to quantify.
Then there are questions about primary pediatric fractures. So what is the earliest stage that one would enter a pediatric condyle?
I think we have Sonal one pediatric trauma lecture, so we can.
Okay, yes. All right. Yeah.
There is one question, Andrew. Do you use any radiological or X-ray intra-op, say C-arm, or does it have any role in seeing intra-op?
I don't, but I'm sure if you've got a method of doing that, you could potentially use that.
Okay. Anything else, Sonal?
No, I'm done.
Okay, there is 1 minute. I have actually a lot of questions. Just hold on. I'll just scrutinize.
Yeah, I have one. Is there any method where we can diagnose disc displacement before or after trauma?
Well, obviously, you can use the standard methods of MRI to determine whether the disc is displaced or damaged. However, you don't know whether the disc was displaced pre-op or post-op. So I think what you're looking for in MRI is more evidence of bleeding within the joint.
Right. So any arthroscopically, can we do an arthroscopy to detect?
But how do you decide that if it is previously there or not? I mean,
yeah,
no, yeah, true.
How do you decide?
Yes.
So there is last question, Andrew. Is disc repositioning necessary if there is no obstruction? I mean.
So I think the answer to that is the same as the answer to the previous one. Do we know if the disc was displaced beforehand? I think if the condyle is displaced out of the fossa from the trauma, then you've got to wonder whether there is any damage to the retrodiscal tissues. If the condyle reduces simply, the disc should follow it, so it should be attached to it. But if the condyle is in the fossa, then one has to assume that the disc is in a relatively normal position and then allow it to heal on its own.
I have one question, Andrew. Do you use any special instrument to retrieve the medially displaced condyle? Say
Yeah.
condylar neck fracture.
So what I tend to do is I will open from above. If I can't reduce it from below, I will open from above. I'll put a 1.5 millimeter screw partially buried into the proximal fragment, grab hold of it with a pair of cockers and pull it outwards that way. And then once it's reduced, I'll slip the dundo tray retractors around it to hold it in position while I repair the disc tear, or the retrodiscal tear probably.
Any questions can still be asked through the chat box, guys.
So during the say bilateral condyle fracture, marionetic fracture, if there is an anterior open bite, if you try to, is there any role of putting a fulcrum at the level of premolar? I mean, do you put anything while you give a elastic traction on this?
I mean, I think, no, I don't.
Okay.
I don't do anything inside the mouth other than correct the occlusion. What you can do is pull the ramus down using, again, a screw or a wire in the ramus and pulling down vertically from below. And that will help to give you a little bit more space superiorly. I think the essential thing with all approaches to the condylar neck and head is to make sure that you release the pterygomasteric sling, because that then allows the ability to mobilize things a lot better and get up higher.
So what is the incidence of facial nerve injury in secondary correction?
Can I interrupt?
Sorry, yeah.
Andrew, are you drawing on the screen?
No, I'm not.
No.
So whoever is drawing on the screen, please stop doing that. It's not nice. Okay. That's Dr. Andrew's cousin. It's not it's not good to disfigure him like that. So whoever is doing that, please stop doing.
They're only jealous because he was a better cricketer than the Indians.
Okay, carry on.
I forgot the question I was asking now.
1 minute.
In secondary correction cases, so what is the incidence of facial nerve injury? Does it increase?
In cases of what, sorry?
In secondary correction cases, when we go back in,
Yeah.
does the incidence of facial nerve injury increase?
So the difficulty with that question, obviously, Sonal, is based on your own experience. I haven't had any patients with any marginal mandibular weakness using a retromandibular transparotid approach, and I've used that approach probably 500 plus times, and I haven't had any with long-term weakness. Using a superior approach for joint replacement, I have about a 1% risk of long-term browtosis. But I think that very much varies with your experience. So,
Andrew, can you just stop your screen sharing?
Sorry?
Just stop your screen sharing.
Okay.
Yeah. Sonal, do you have any question?
So one question was that after we distract, we know that in children, it's going to go back again, going to relapse quite a bit. So is there any way of preventing all these secondary deformities after distraction?
Sorry, I missed that question, Sonal. I was switching off my computer. I've got all sorts of lines over my screen at the moment.
Yes, sir. No, so there was one question that after distraction in a child or in a young adult, there are chances that he might go back to the various facial deformities. So is there any way to prevent that from happening?
I think, like with everything else, I will tend to get the patient in light elastic traction for a couple of weeks and then mobilize them as soon as possible. A functioning joint heals itself. So
Right.
I think really getting things functioning is the best way to manage it. The other thing to say is that we know that the occlusion will change slightly over the course of 6 to 12 months. So patience is a virtue in any form of TMJ surgery or orthognathic surgery. So just allow time for things to settle down. With the distraction cases, if you've developed an anterior open bite, you can always release the distractor a little earlier and put some anterior traction on to close that and in what we call manipulate the callus.
Right. I think we are done. Nehal, do you have any more questions? Nehal? Nehal, are you there? Is anyone there?
I can stand in for Nehal.
Okay. All right.
It's frozen.
Any more questions?
Hello.
Yeah.
There are people still trying to join the meeting.
Trying to join?
Yeah. Yeah. So we still have about 220 people attending the meeting. So if there is anything that you want to bring up, Sonal, are you getting any more questions?
Any damage to lateral pterygoid attachment after TMJ replacement?
Yes. So you detach the lateral pterygoid with at joint replacement. You don't reattach it. And that's one of the reasons why they may end up with a persistent movement towards the side of the joint replacement. And they don't, if you do bilateral joint replacement, you don't get much AP or lateral movement at all because the lateral pterygoid has been detached.
So Andrew, you said the Great Ormond Street people are doing joint replacement at a younger age. Did I hear you correct?
Yes.
Are they doing it according to a protocol, or are they doing it for ankylosis, for any pathology, and how young?
It tends to be for the ankylosis and the craniofacial cases.
Re-ankylosis in craniofacial cases.
Yeah, yeah.
And how young?
And craniofacial cases.
Okay. And how young are they doing that?
I haven't spoken to Nad for 2 or 3 months. He started off at Great Ormond Street just over 18 months ago, and the last time I spoke to him, they were lining up cases 6, 7, 8-year-olds.
Say that again. What age? 8 years.
6, 7, and 8-year-olds.
Okay. So they intend to replace the joints as the child. It's not that you have to replace the joints as the growth happens.
Yeah, I mean, I think the increasing understanding is that if we replace the joint early, yes, we may need to revise the occlusion down the line, but they don't end up having multiply operated failed chondrographs. And that seems to be significantly more craniofacial anomalies tend to have more failed costochondrographs than the straightforward post-traumatic ankylosis.
So there's one question: how much can we supra-erupt, or hope the maxillary teeth will supra-erupt to correct the cant? To what extent can we not do the leaf osteotomy and allow?
So I've had patients close a lateral open bite of 8 millimeters.
8
Without
millimeters.
any difficulty.
Okay.
Yeah, they close within weeks. You'll see the patient probably 6 months down the line, the lateral open bite's completely closed. So a girl that I treated in January last year for an ankylosis, she was 14. I distracted her ramus 10 millimeters long. When she came back to see me for removal of the distractor, the open bite had completely closed. And then I did a joint replacement, lengthened her another 5 millimeters, and the lateral open bite closed again.
So the cant corrective.
The cant corrective, pretty much so. She had a pre-op about 13 millimeter cant. By the end, it was about 3.
Okay. So there's one question. I'm not sure what it
So,
implies.
but then that would only be dental correction, dental supra-eruption.
Yeah, it is. It's dental-alveolar.
So the periodontium, and then what happens in adults? In children, do we expect dental-alveolar compensation, or is that only dental? And then in adults, what happens to the periodontium then?
I think you
With
can
10
expect.
mm supra-eruption.
Yeah, I think you can expect dental-alveolar compensation in anyone up to about 20. But literally just expect it. Don't do your LaFore-1, wait a year. If a year down the line they've got a malocclusion, then you can correct the cant.
Okay. Can I ask Sonal?
Yes,
So,
please.
The question is, in general, why do we have such a guarded approach to joint replacement, I suppose, in TMJ compared to the knee or hip replacement?
I think it's really related to the fact, I'm hoping there aren't any orthopedic colleagues listening, but they tend to treat joint replacement or use joint replacement for treatment of pain. Now, I know in the UK, there's been an investigation into this over the last few years, and they feel that up to 50% of patients who've had joint replacement actually didn't need it in the first place. They could have been dealt with much better by less aggressive methods of management, in particular weight loss and pain relief. So my wife does a lot of pre-op anesthetic work, and she sees patients who are medically significantly compromised, who are overweight, have no chance of getting back to walking again, that are listed for joint replacement. And the risk of death during the procedure is around about 20%. And they haven't even tried paracetamol for pain relief. So I think we are probably on the opposite side of that spectrum, in that we very much say, actually, joint replacement isn't a treatment for TMJ pain. It's primarily a treatment to improve TMJ function. And therefore, what we're aiming for, and particularly in the UK, that's very clear from our national guidelines, that joint replacement is to improve opening and chewing ability. It isn't primarily to improve pain, although we know very well that it does improve pain in a significant number of patients. A lot of the patients that were operated on in the US in the 70s and 80s and had alloplastic replacement were done, or even had open joint procedures, were done primarily for pain, and they were misdiagnosed. These were patients that had myofascial pain, not joint-related pain. And I see probably 10% of my practice in alloplastic replacement are on patients who've had multiple procedures done elsewhere, in the Einstein principle of, I've done this, I'll try it again, it didn't work the first time, I'll try it again, I'll try it again. And then they end up with a degenerate joint because they've had multiple operations. Those patients don't do very well, and part of the reason for that is that probably they didn't need an operation in the first place. So I think that there is a degree of reticence because of our past history of joint replacement failing, and also a degree of reticence in terms of the fact that a lot of people don't make the correct primary diagnosis.
Andrew.
Hi, Nehal.
Hi. So how soon do you initiate the physiotherapy after refracture fixation or maybe bone graft?
So I will start the patient moving within 2 weeks. After a joint replacement, they start moving the next day.
Okay.
So there's another question. Dr. Sidebottom, how long is your follow-up with secondary condylar osteotomy along with a bone graft? How is cancellous bone graft retained in the gap? And does it work with mini plates like the case that you have shown?
Yeah. So the answer to that is the first condylar osteotomy I did was now 2010. And I see them up to 5 years and then I discharge them. And I tell them to get back in touch if there are any problems. So I can only say that I've got 5 years follow-up, but I know that the patients that are 10 years down the line haven't been in touch. So I'm assuming they're okay. The second question is chips. I pack them into the defect, similar to what you would do for any non-union. So they get packed into the defect against the medial periosteum. If the gap is quite large, I will tend to put a small cortical block on the medial side to facilitate something to pack against. So, but I just literally pack it up against the block. Do I use mini plates? Yes. I tend to use the Synthes 2mm plate with the broad or the thick gap rather than the standard gap. And I use 2 of those standard rather than the Delta or the Lambda plates. I'll use 2 straight spaced Synthes 2mm plates. And I haven't had any of those fail.
Okay. So another question is, do you place the patient on in IMF after TJR or TJR with concomitant maxillary osteotomy?
So post TJR, no, unless the joint dislocates during the operation. If I can dislocate the joint during the operation, I will put them in light elastic traction for 1 week and then mobilize them. Post orthognathic, again, no. By and large, they can mobilize very well. It's often difficult to explain to the orthodontist that they can't manipulate the mandible into the right position when you've done a TJR, because it's a rigid fixed position. Whereas when you've done a sagittal split, there is a degree of mobility at both the osteotomy site and also in the region of the condyle. So saying to the orthodontist, look, there's no point in putting elastics on. You won't adjust the position of the mandible by doing that. All you're going to do is move the teeth. Then they suddenly appreciate that, and then they wait until 6 weeks down the line before they start their dental finalization.
There's a question. What is considered to be the best amongst buccal fat pack, abdominal dermal fat, radiation, and NSAIDs to prevent re-ankylosis after TJR?
So after TJR or ankylosis, I will pack abdominal free fat around the defect. I don't think there's evidence in the literature to say that anything is better or worse. And the evidence for packing fat around the TJR is really restricted to Larry Walford's practice, where he feels it works much better at reducing the risk of ankylosis.
Okay. Do you have any more questions, Sonal or Nehal?
Nehal?
No.
Done.
So that's good. We are at 1.5 hours into the session.
Yeah, almost. It's 5:30.
Yeah. Yeah. So shall we call it a day?
I think that's reasonable.
Thank you, Dr. Andrew. That was a wonderful
Thank you, sir.
presentation.
Thank you very much.
Thank you so much.
And everyone stay safe.
You too.
Andrew, Sonal, Nehal, Amit, please stay back.
Yeah, okay.
Kanan, if you're there, please stay back. Preetham, if you're there, please stay back. Thanks everyone for joining in, and please do attend tomorrow's meeting. There is another talk by Dr. Moni Kuriakos tomorrow at the same time, starts at 4 p.m. Okay. We will be sharing the meeting ID, like how you got the meeting ID today. So do join in tomorrow. Tomorrow's meeting is, tomorrow's lecture is on advanced buccal carcinoma management. And there is Dr. Prasad Narayanan, a medical oncologist, joining, and Dr. Rahul Thakur from
Barodara.
Yeah.
Yes.
Yes. Preetham, as usual, you have joined, you have come to the class late. Preetham, can you hear us? Oh, I have to unmute him.
Yeah.
Oh, wait. Preetham.
Hello. Yeah, Preetham.
Yeah, I
As
can
usual,
hear
you
you.
are late. As usual, you are late for the class, Preetham.
Bugger, I was in and then I was giving some
Still there are 14 participants, man.
listen.
I saw you asleep for 2 minutes.
No, I was forwarding the YouTube link. I come back. I am out of the Zoom. But I think it was a good thing I went to the YouTube because I could take questions from there.
Right.
Yeah.
I think it was a good move, but whatever it is, it became a good move finally.
Yes.
Yeah.
So I think we are still live on YouTube. Somebody, we need to stop that.
Yeah, you'll have to tell.
Okay, let's join Praveen and then cut off everybody else and do the meeting.
I am kind of stuck. On
How do you
my
cut
Okay,
off
call
people?
Praveen on the phone. Pramod, call Praveen on the phone.
I'll call him. I'll call him.
Yeah.
Is Andrew there?
Yeah.
Yes.
he's still there.
Yes, yes.
Andrew, we really thank you for a wonderful lecture. It was fantastic, and we apologize. I got a lot of message from many of people from our members to personally apologize to you for that drawings on the screen by some of the students.
Yeah.
You know, it's some naughty students would be a good surgeon tomorrow who's doing his artistic work. He managed to get into your screen, you know.
Praveen.
So we're extremely
So-
sorry.
Stop the
so-
live
so-
stream on YouTube now.
So Preetham and Praveen,
Yes.
see, there is a. I think as the admin, Praveen,
Okay.
there is a
So,
setting
actually,
to
we
prevent.
want to continue meeting, 5
Yes.
of us. So shall we
Yes.
do it again? Okay. Okay.
Yeah, let's do
Preetham,
it.
Preetham,
Yes.
it is not possible to stop a live stream unless we stop this meeting. So we
Okay.
log out and
Yeah.
log in again.
Okay, let Praveen call us separate then, not with the meeting ID.
Yeah. Yeah.
Okay.
So
Send
let,
another meeting ID, Praveen.
No, we won't use the meeting ID, Pramod. We'll have
A
to
new
do with
meeting.
the demo one.
I'll make a
30 minutes
meeting ID
meeting.
from my
Yeah.
side.
Make a new one.
Preetham.
Huh?
No, listen,
Yeah.
Praveen, are you here?
No, Praveen
No.
is not there. So we'll
Okay.
Nehal,
Yeah.
let Praveen do through the demo model,
Okay.
not
Yeah.
through the paid one.
Praveen will call everybody. Okay.
Yeah.
Okay,
We
guys,
need
thank you.
Praveen.
Thank you,
Yeah.
Nehal. Thank
Thank
you,
you.
See
Sonal.
you
Thank you,
soon.
Pramod, for the wonderful
Thank
session.
you.
Thank you.
Thank
Thank
you.
you so much.
Bye-bye.
So we join back, all of us, in another 10 minutes. Thank you. Bye.